Good morning, CLAS. Really? Oh my goodness, I know it's Thursday. I know we're 4 weeks in, but we're going to do that again. You can be louder than that. Good morning, CLAS. All right, thank you. It is so wonderful to see all of you here today. I want to just start by seeing how many students we have in the room. So students, I saw you taking selfies for your classes. Raise your hands. Thank you. Of those students, how many of you are not CLAS students? All right, a number of you. Excellent. Well, we're so glad that you're here learning more about what a liberal arts and education offers you, whether you're in the School of Engineering, whether you are in SPA or some other college. For hundreds of years, a liberal arts education has been the foundation of much of higher education. And the skills that we learn in the College of Liberal Arts and Sciences transfer to all aspects of our everyday life. And we know from research study after research study after research study that the ability to communicate well, the ability to think about ethical and cultural considerations transcends industries. So you are in good hands with your CLAS education. My name is Lisa Karanin. I almost said I'm the chair of communication, but that's a lie. I don't do that anymore, but I'm a professor of communication, and I'm delighted to be your host for CLAS MixTape. We have a great program lined up today. I always say that today is especially true, and I am so excited that we have amazing speakers and an award-winning student poet to really showcase all of the good work that happens in the College of Liberal Arts and Sciences. So show of hands again, how many of you are here for the very first time at a CLAS MixTape? Raise your hands. Excellent, love it. Okay, so let me just say then that the purpose of this series is to showcase the research, teaching, and service of our faculty, our students, and our alumni and staff. And so we do that with short but hopefully compelling presentations on a variety of the projects that CLAS faculty, staff, students, and alumni are working on. So today we have undergraduate students and we have faculty. They represent all ranks of faculty, and they also represent the four main divisions in the College of Liberal Arts and Sciences, and we'll talk about what those academic divisions are in a moment. So last year we kicked off this new series. In September, we addressed racial equity and work in CLAS that addressed racial equity. We then turned to democracy and how our work across our divisions makes communities stronger and makes democracies stronger. We then dove into climate change in November, and then decided we need a little break because that was a rather ambitious lecture series, one right after the other. And in February, we collaborated with Laura Argus and the ORCA office in CLAS, the Office of Research and Creative Activities. And we had a big old celebration right here in this room. There's some photos of that celebration. And in particular, we were celebrating our leadership as a college in collaboration in research and creative activities. And Julian Longu, who is still the chair of math, made a binder from faculty activity reports of the amazing research that faculty did. And students, it's so cool to get to work with faculty who are producing original research and art and so on. And over 2 years, we published more than 740 journal articles, essays, book chapters, more than 30 scholarly books, 75 creative works, and we averaged over 2 years, actually a 3-year period, more than $7 million in external research funding. So we had a lot to celebrate, and I hope that you'll consider joining us this February when we celebrate again, because we've already got amazing and award-winning books published. There's a lot of exciting things happening in CLAS, and those of you who've heard the dean speak so far this semester have heard a couple of our new programs that we're launching, but there's two in particular that I'd like to talk about that are related to today's topic of healthcare and medicine, and that is our MS in clinical psychopharmacology, which is enrolling in a way that exceeds all projections and expectations. We are so excited and so grateful to psychology and to Amy Walkos for getting this program off the ground. We also have a new degree in climate change studies launching this year, which definitely is related to healthcare. And for the students in the room, you know, health is both a universal human concern and need, and it's a potential career trajectory regardless of your school or college, right? There are many and growing jobs in the healthcare sector that have to do with engineering, that have to do with design, that have to do with all sorts of things. So we also have on the tables a list of programs that are offered, some of which are just certificate programs or minors, that with a few credits, you could add this to your certification and, you know, have a leg up, if you will, when you are on the job market in a couple of years or next year for the seniors. So please take a look at that and ask one of the faculty in the room if you have any questions about them. All right, so the way MixTape works, oh, one more exciting thing, and unfortunately the director of this center had a long-standing previous commitment on this day, so he could not be here to tell us about our new CU Denver Center for Psychedelic Research, housed in this building, I understand. And there is an amazing CPR story profile of this faculty member's journey. So here's a screenshot from that, but I encourage you to Google it if you have not and read about the use of psychedelics, studying psychedelics and how they can benefit cancer patients. So check that out. It's another example of the exciting and cutting edge work that we have in CLAS. All right. So the way MixTape works is that we start with a poem. And we are so fortunate today to have one of our award-winning undergraduate poets who's a creative writing major, who has received the 2023 Ruth Weiss Emerging Poet Award. And I have to say, has published in some pretty amazing venues for someone who hasn't even graduated yet. So we are going to hear from student poet Asma Al-Masyabi. This poem, woo, yes, let's hear it for Asma. For those of you who like to read along, there are a few copies of the poem on your table, the smaller sheet of paper. And this poem will really call us into a reflective mood so that we are focused and ready for our talks today. So Asma, thank you so much for joining us.
Thank you. All right, can everyone hear me? Reasons for blue. The curve of sky was a swallow that would not stop singing. The clouds, like veins let loose, made me think of the ways burned set, like temporary tattoos. My arms patched with skin touched lightly darker. I can never be too mad at a pain lingering, storied in marks that make history of my body. Dip the heat in honey. When I shattered, I waited for confirmation before slipping that I was not okay. The truth is only real when it bleeds a bit too much on tile. Threatens to stain, and not before. Feeling is not enough to be taken. Some days the sky is all clouds and the sky is gray-white, and the sky and the clouds have kissed too deeply to be called two things. I know someone who thinks every hurt is a shadow waiting to concrete. I know someone who calls every pain into question as if it is lying. Each wince a collection of thoughts, threading unbidden, the throbbing a distrust of what level of sky is the truest if the sky exists. Once I fell and I could not get up. Once I got up, and when I fell, I laughed because it had been too long since life hurt so sharply in one place. I got up and wanted to fall again, but couldn't. So I pressed hard, sky-colored bruise, steeping edgeless into the song of alive again and again.
Thank you so much for sharing your fantastic words with us today. All right, so having called ourselves into reflection with reasons for blue, it is my great pleasure to introduce you to someone who does what I do, although in many ways better, and it has more cool projects. And so I'm about to introduce to you somebody who does the rhetoric of health and medicine. So this is a representative from the humanities. So Carrie Campeau from English is a rising star in the rhetoric of health and medicine, and she publishes in all the best outlets for our area of work. And what's more significant, I think, is that her work with immigrant communities who are vaccine hesitant is used in graduate classes across the nation. And so it's an example of a study that was inclusive, participatory, ethical, and impactful. And so it is my great delight to turn the microphone over to my colleague, Carrie.
So since 2013, I've been studying vaccination controversy through the lens of rhetoric. My talk today focuses on why rhetorical and humanistic approaches are important to big, intractable health problems like vaccine dissent. Humanistic research can surface how science and medicine descend into people's everyday lives, which is where health decisions happen. So there's a lot of different definitions of rhetoric and rhetoric of health and medicine, but here's my summary. As a rhetorician of health and medicine, I study how people engage with systems of health, medicine, and healing. And I map how concepts like health, medicine, care, or in this case, vaccines, immunity, public health, are constructed through language use. To do so, I often start with looking at the dominant discourses or the way things are framed. When it comes to vaccination, vaccine dissent is often framed as a problem of wrong belief. People who don't vaccinate believe the wrong things. Maybe it's because they don't understand science, or they've fallen prey to disinformation, or they're selfish. Whatever the reason, when non-vaccination is framed as a problem of wrong belief, there emerge two logical, worthwhile responses: persuade people to vaccinate, or mandate vaccination through regulation. So these are important tools in vaccine policy, but they only tell part of the story. Today, I'm going to challenge the wrong belief model of vaccine dissent by presenting and discussing two stories from past studies. Here, I approach vaccine hesitancy not necessarily as a wrong stance to be corrected ASAP, but as a rhetorical move, as a rhetorical refusal, a way of participating in healthcare. So a lot of my research is ethnographic and interview-based, and I work in a lot of different communities and contexts to understand how vaccine decision-making is happening here. And these are two stories from that kind of work. So first we'll begin in Minnesota. Minnesota is home to the largest Somali population in the US, and it's fall 2017, and the Twin Cities are recovering from one of the state's biggest measles outbreak. This outbreak mostly affected under-vaccinated Somali children, and it was definitely framed within the wrong belief frame. There were sort of two agents of blame in public health analyses and news coverage, and those were national anti-vax groups who descended into the Twin Cities, really targeted Somali immigrant communities with disinformation. And then, and this was very much a self-critique, public health who underfunded like most public health departments, but struggle to provide proper outreach and build relationships with their Somali residents. So these frames are accurate and important, but as you might notice, they flatten the agency of the people actually making vaccine decisions, Somali parents. So at the time, I was working with a Somali Women's Health Center and talking to a lot of these parents about vaccine decisions, and the stories I heard didn't really map onto these frames. So, for example, one mother related the following story about why she didn't vaccinate her children. And importantly, she started this story by talking about how great she thought vaccines were. They were life-saving. She had seen the effect of under-vaccinated communities firsthand. But she specified that I know there are studies that say vaccines do not cause autism, but they haven't done studies on us. Our children have been immunized more than American children. We live in places with pollution, bad air. With my son, he had 3 rounds of the measles immunizations, and this was at different stages in migration and resettlement. So she was particularly concerned about how the MMR vaccine was administered in the US to Somali children specifically. And she worried that evidence supporting the safety of this vaccine didn't have much bearing on her family's embodied experiences, which were shaped by war, displacement, forced migration, and ongoing structural precarity in Minnesota, and which crystallized in certain specific somatic experiences, such as multiple rounds of the same vaccine. Importantly, there's no evidence that receiving extra doses of a vaccine causes any health harm, but this participant's worry wasn't relieved by that population-wide evidence. Rather, her concern was magnified by her experiences of having her family's health shrugged off in other contexts, like living next to a highway, breathing in polluted air, struggling to find housing. And so in these experiences of feeling very outside of the public health, non-vaccination became a kind of protection, constrained protection that she could offer her child. So, story 2. Now, we're in early 2021 and COVID vaccines are rolling out in phased distribution. At this time, I was working on a study about COVID vaccine decision-making with pregnant people. And the following explanation comes from a pregnant woman living here in Colorado who was eligible for COVID vaccine, but had held off because, in her words, I wanted to wait until after my first trimester because the last thing I wanted was a fever. My OB advised to hold off because my job isn't high risk and the trials didn't have pregnant women. A lot of participants had advice from their doctors along these lines. I also, and this was February-ish, so I also really want Moderna, I think, because if I'm going to do this, I really, really want my baby to get some antibodies. And then she talked a bit about her own investigations into vaccine response and its differences by brand. So this participant was not alone in spending time and energy trying to optimize her vaccination. Not unlike the Somali mother I quoted previously, she was worried that her needs and experiences, this time as a pregnant woman, were not included in the data being used to recommend COVID vaccination. She felt like she had to do all her own research to be a good healthcare consumer and to be a good mom. And so she remained in the unvaccinated camp until, as she updated me, a few months after giving birth. And she reported that she felt really good about her decision. She felt really empowered and informed, but it's worth noting that her decision really worked against public health goals and probably put her own health at risk too. I mean, she waited nearly half a year to get vaccinated. So these are 2 very different stories, but across both of them, neither participant's reasons for not vaccinated could be distilled to bad information or a wrong belief. And in fact, in interviews across lots of studies, when we start talking about vaccines, we very rarely spend much time talking about vaccines. Instead, we end up talking about raising kids, about pregnancy, about healthcare and ERs and worries about pollution and what's in your shampoo and public schools and costs of things and all sorts of contexts, because these are the super local contexts in which people were understanding and making decisions about vaccines. And importantly, they had very little to do with science. As these stories illustrate, they also had a lot to do with people feeling like their needs were outside of the purview of the public health, like they had to forge their own paths because they weren't included in evidence, whether or not that's true. Which gets to why humanistic approaches to understanding medical dissent are really important. These approaches offer us ways to understand vaccine resistance, not as a scientific problem, but as a social problem, and one that in turn calls for social solutions. So humanistic methods of inquiry and analysis are also really exciting because you get to follow people's stories and really listen beyond whether their claims are true or false scientifically to these different visions of community health and what belonging and real trust in medicine could look like. And that's beyond the scope of my talk today. So I'll end with that humanities research approaching the lived context of health decisions and really listening to claims outside of their scientific veracity is hard, it's messy, but I think it's really essential and we have the skills and tools to do it. Thank you.
All right, so one of my great joys in getting to work with colleagues to put these programs together is just meeting people that I'm continuously in awe of. And so today I'm about to introduce you to a remarkable graduate student from medical anthropology, who was also, medical anthropology, also an award-winning Army medic and harm reductionist / outreach worker. So you'll see one of our through lines for health research in CLAS is partnering with stakeholder communities. She did this in a way that transformed her ethnography graduate seminar final paper into some public scholarship. And here to talk to you about that today is the fabulous Nikita Burgess from anthropology. Come on up, Nikita.
Hey, y'all. Thank you so much. Is this on? Okay. Sorry. Thank y'all for being here. Very excited. Oh my gosh. During the seemingly endless slog that is summer in South Texas, the smell of cayenne pepper from the La Fiesta Spice Factory caustically mingles with engine exhaust. Suspended and heavy in the suffocating humidity. In traffic, I creep slowly toward downtown, the vast skeleton of IH-10, experiencing this city as it was famously brought to the world in REM's music video for Everybody Hurts. Hidden behind the on and off ramps and pylons and retaining walls exists an often invisible slice of our community. This is where he died, alone. Again, my eyes well with tears. Danny, a slight soft-spoken man in his early 20s, had approached me the weekend prior at a syringe exchange where I spent most Saturdays volunteering. "You're the outreach worker. Can you help me get my ID?" he asked, softly, cautiously. As the line began to swell, I hurried him through my station, agreeing to meet with him in the coming week near his encampment to start this overly complicated ID recovery process. I never saw him again. Danny died, overdosing, tucked away from our line of sight in the shadow of I-10. That's an excerpt from an article I wrote called Displaced to Death, which originally was a research paper I did in a ethnography class in my first semester here at UC Denver. It was then part of a monthly emailing campaign that I do starting this year, where I send emails to local officials, media, and stakeholders back home in Texas regarding my former clients and the issues of morbidity and mortality that are connected to encampment sweeps. These are some of the places where encampments existed, but no longer as they were swept. This then was requested to become an article within Deceleration and the Texas Observer, where I worked with a editor from UTSA to make it something for more public consumption and not so academically driven. In this vein, I am drawn to an arts and activist approach to anthropology, which infuses creative expression with, social justice advocacy and all of these things, looking at and bringing research, theory, and practice to the public. In using this approach, it's both a method and a medium. And I think that it's a wonderful way to help others interpret anthropological knowledge. And I think it's probably ubiquitous that art has this capacity to communicate the embodied, emotional, and sensory aspects of what we're trying to convey here academically. Both of these things, arts and advocacy, aim to uplift the voices of people and communities that we work within, but we are trying our best to form thick solidarity with those folks. This is about not just documenting them and their stories, but raising up their voices and, of course, allowing them to be in active collaboration with these things. I think I skipped ahead on my slide, sorry, y'all. Activist anthropologists and arts-based anthropologists can also help to facilitate these things through community-led initiatives and projects. And they really help to articulate some of these social injustices that we look at in this field, and help, of course, to engage a wider audience than just academia. So with zines and with graphic novels, these things are, first, the graphic novel is a little longer, if y'all don't know what it is, and has a little more in-depth storytelling, and where zines are, of course, more DIY and self-published in nature. This piece was also a project I worked on as a final, but it was also a way to process emotions of losing a client I had become very close to when I worked in outreach. He passed away in police custody, and it also became yet another email that I send out monthly as this project progresses. I was so happy to be introduced to this medium as an academic form through my wonderful advisor, Dr. Antañez, who, as part of his COMIRB approved research study, I am also involved in, and we are working with other individuals with lived experiences to put together a separate work, a graphic novel that really touch on personal stories of drug use, overdose, and of course, the being subject to carceral approaches in the absence of liberation harm reduction strategies. These types of public-facing work help to spread awareness and foster dialogue on these critical issues, such as overdose, environmental justice, human rights, and social inequity. So on that note, I'll close it with another excerpt from my piece. Someone I greatly admire once told me, this country doesn't have human rights. We have civil rights. And as I sit with that eviscerating truth, the web of cruelties that are anti-homelessness measures, abatement, move along orders, hostile architecture, drug war policy begins to unravel. All of these components of structural violence work to exclude people not only from achieving basic health and dignity, but ultimately their place in civic life. I write this miles away, both temporally and spatially, from my days spent working in outreach on San Antonio streets. I ultimately left my work in outreach without having secured employment, found my way here to UC Denver. And still, my guts churn at the thought of what my former clients might think of this writing. The thought that I have abandoned my community for the comfort and distance of academia. At the risk of projecting my constant feeling of hopelessness, my fear that all this writing, the countless emails to local officials, is ultimately a useless endeavor. It won't bring Danny back, nor the innumerable others who languish and die right before our eyes as a direct result of policy failures. These deaths are a reminder, one that often violently bumps up against my self-righteousness, that no matter how well researched our writing, no matter how well explained our emails to city decision makers, the real question remains: how do we reach inside the chests of people and get them to give a fuck?
All right, very powerful work. Thank you so much, Nikita. We're going to switch now from the social sciences to the natural and physical sciences, but you will see a couple of through lines here. In addition to partnering with stakeholder communities, collaborating, you'll see this creative spark that runs through all of the presentations, even when you're doing statistical analyses of big data sets, which is not at all my area, but I am so impressed with Erin Austin, a faculty member in the Department of Mathematics, who is very humble, but has really impactful medical publications that have a lot to tell us about genetic risk and how different illnesses and conditions that seem connected might in fact be connected, right? The sort of things that we can't figure out why, patients who have condition X have condition Y as well. And so his really creative work lets us see some of those connections. So let's hear it for Erin Austin.
All right. Thank you for letting me be here today. To get things started, you can see the title of the talk, but I realize as I write this is really just my way of saying I'm the biostatistician on the panel. It's nice to meet everybody. But to sort of help our discussion today, I think maybe one of the most important things to think about with data is to think about who actually is the data. And we're talking about equitable access and things like that. I want to just kind of actually put the question to you, because I think a place to start is to start where to figure out what matters most to people. If you want to impact people, it's to figure out what they're going through, what their experiences are, and to try to identify opportunities to help people. So a classic way public health will do that is to sort of think about different sources of data. You have your classic genetics, which obviously I love, but you're thinking about where you grew up and thinking about your environments and thinking about your choices now and in the past is an important part of understanding the opportunities in public health. And so to sort of weave in how a statistician might approach this and hopefully do ethical and equitable research, I've put a number of questions up here. And we sort of think about the population. Is everybody going to have an equitable access to benefits of the research, any findings? And we have to hold ourselves accountable to make sure we have accurate representations of any system. And the last one is sort of the plug for stats, the questions that maybe I will hone in on. But I also want to say this is why I love being under this world of CLS and the med school in general, is that nobody can answer any of these questions. It's a diverse team. Without people like Nikita, we're not going to know how to properly identify populations and have the best ways to access or to help them access benefits. Without people like Carrie, we don't understand the complexity and nuances of system. We might not even have the right questions. The third one is why I sort of like being in a math department that's also a stats department, because you get to leverage every tool you can think of and, hopefully find something that helps. But to frame our discussion today, if you allow me to talk a little bit about a research project with one of these diverse teams, I'm hoping to sort of introduce you to a really important problem that we've all heard of. It's smoking. And just to give you, attach a number to it so you have sort of a scale of the problem, but also scale of the potential impact. 2021, 11.5% of adults. And the thing I would highlight in addition to that is that's 16 million people that are living with the disease as a result of their smoking. And that's 14.5% of the people in Colorado. So not only do you have this opportunity, hopefully, to impact smoking cessation, things of messaging, things of dissemination that Karen, who speaks after me, would be an expert on. We also have an opportunity to impact people on the side of resulting diseases, maybe prevention, maybe mitigate the effects of them. And related to smoking, the thing that you may have heard of already is most common is this idea of COPD, chronic obstructive pulmonary disorder. This is a really symptom-heavy definition. You're having trouble breathing, you go to the doctor and they diagnose that, and they rule out asthma. They ask you if you smoked, and so they said, yeah, you have COPD. But the limit to this is that COPD isn't honestly a real thing. It's an umbrella definition. And this is where learning the public health, working with the experts at Anschutz, you start to see, well, if it's umbrella definition, if it's just lumping a bunch of different diseases together, does that mean that we can start to have more opportunities to refine our studies and hopefully help more people? So what do I mean by that specific to COPD? This very dramatic figure, and I tried to find the least dramatic figure that I could on this case. I ran it by my kids to make sure it was slightly less dramatic than I wanted it. Two examples of what COPD might really be measuring. On the bottom, you see these things that kind of look like grapes, and this is emphysema. This is one thing that sometimes gets sucked up into this umbrella COPD definition, and it's the loss of lung tissue. It's gone. But another thing that is often not thought of as COPD is what we call airway predominant disease. It's the airways that you breathe through being restricted, being blocked, inflammation causing you to simply not be able to breathe as well. And so we have these different disease processes. And so maybe we can refine how we reduce the number of deaths, the sixth leading cause, but maybe we can also start reducing important secondhand effects of this, smoking to COPD, to something besides mortality, and something that will impact us all. And as we've heard, will impact us more and more as we have an aging population. We have pollution, as Gary mentioned, and smog, all of these things. It's this very natural, intuitive argument that if you're struggling to breathe, you're struggling to get oxygen to your brain, there's got to be some consequence of that. And so I just grabbed this table of information maybe a couple days ago to show you that by this definition of people saying, over the last year, I'm struggling with my memory, I'm struggling with confusion, we see on this very bottom line here that of the people that have COPD in this slightly younger cohort, it's 22% to 6%. So about 3 or 4 times as many people are having cognitive impairment than are not. And even in the slightly older cohort, it's still twice as much. So where does my research team and the people I feel really lucky to work with come into play? Like, where is the scientific contribution that we're hoping to make to this public health problem? It's related to trying to find a mechanism, trying to figure out exactly how is this breathing concern affecting your brain, because that's your opportunity. That's your potential place where you can develop a treatment, you can develop an intervention, things of that. And there's an existing hypothesis that's not really well established that it's actually not emphysema, it's actually your airways that are causing this. And that's what I'm representing on this slide. Okay, so to circle back to where the statistician might come into play, it's at this modeling level, hopefully building off of everybody else's expertise, and it would be nice if the model was this simple. But as we all know, I started out with a question of how do you want people to use your health data? And that shows you there are so many variables over a lifetime of exposures that are going into this very simple arrow. So that's where I get excited about being in CLS, because I get to borrow from all my mathematical colleagues to do things like this. To do something that's what I'm showing here is just what we would call a network model. It's trying to say we have all these different variables that represent this holistic view, all these different variables that could be interacting and explaining some of what's going on, but also at the same time, they interact with each other outside of the cognition question. And just to kind of orientate you to this, on the right-hand side is a list of a whole bunch of individual variables that have evidence existing that they're related to cognition or smoking. But they've been studied individually, one at a time. So to truly understand, to try to tease out the mechanism here, we need to study them as a system or as a network. And so each of these little nodes are, each of these circles are representing one of these variables, and these lines between them are representing their relationship, with the thicker line being stronger. And why I particularly like this mathematical tool is these lines are actually representing how these variables are related after taking out the effects of every other variable in the model. And even more, after taking out the effects of every other variables interacting with each other. So we are really starting to tease out these independent effects with a standard model tool. And so just highlights this top left diamond is the cognition variable. There's smoking variables. And then these blue ones are actually their emphysema and our airway disease. So we've got it all in the model. We've let it try to talk to each other. And then where does the stats person come in? So to circle back to that last question, what can we say besides just saying, look at this map of this data and it's exploratory and there's a lot of potential here? What can we actually say is real? What can we say goes beyond our data that we can generalize to those populations that we're talking about? And that's where stats gets to jump in and say, well, what do we think is real and not just a random effect, the strongest evidence? And when we do that, when we apply this filter, my colleagues and I have landed at this as what we think is really the phenomenon. And to point out again, this number one trait here is actually our cognition. And this number 7 here with this bright red line is actually that mechanism. So this is some of that early evidence of the specific process, not just this umbrella COPD that lets you say, all right, here's where we're going to study next to hopefully help people. But I'll also point out these bright red things are really just variables that are summarizing things. And then I go back to my CLS colleagues, my experts, to say, these variables are masking something systematic. Who isn't having access to education? Who is actually potentially being discriminated against, or is at least not getting the information they need? So, okay. So that's an example, and I appreciate your time.
Great, thank you. So one of the challenges of this program was that there is so much research in CLAS about healthcare. And when the 4 of us were getting together to talk about, well, what are we going to talk about? And what do we want to highlight? And what are the connections? We realized that there's so much work that we can be doing as a college to collaborate. And so for all the scores of health researchers we have in CLAS, don't fear. We're going to try to do some collaborative work that builds off of all of the connections that we get when we put a Nikita and a Carrie and an Asma and an Aaron and others in the room. And the person most excited about this was my colleague, Karen Lutfi Spencer. And this summer, what I loved was that Karen was in the media all the time, popularizing a concept that she had worked on many years ago that didn't get picked up at the time, but certainly did this summer, and that was medical gaslighting. And so I loved being able to share online with Carrie and my rhetoricians of health and medicine that I had this great colleague in my college who was doing the medical gaslighting research before it became popular. So the thing is, Karen was the one who was most excited, and life happened, and she could not join us here in the flesh today. However, she's so amazing, she made us a video. So we will get to see Karen talking about medical gaslighting while our emergency tests continue to beep in the background. Thank you for being so gracious about those sonic interruptions. All right, so Karen is widely published. She is representing the integrated sciences. Health and behavioral sciences is her department, but she's trained as a sociologist and has published for decades in many of the leading journals in her area, and has also been widely cited in mainstream media. So without further ado,
Hello,
Karen.
my class colleagues and friends. Thank you so much for including me on this wonderful panel. I sincerely apologize to Lisa, who is the most calm and collected organizer ever, my fellow panelists who gave such amazing practice talks, and to all of you for this just unavoidable change of plan. The topic I would like to bring to this discussion is about dissemination. So let me set the stage for you first. The year is 2000, University of Minnesota in the Twin Cities. Young Karen has taken her brand new PhD to start a tenure track assistant professor job in the Department of Sociology. And there's three features of this intellectual landscape that many of you may relate to. First, when I say to people that my research is about how inequality emanates from inside of healthcare, people don't get it. They all assume that the barriers are all about being able to access care and to be able to pay for it. But the idea is out there that once you see a doctor, you're golden, everyone gets treated the same. Number two, being interdisciplinary is still pretty unusual. And three, at least in sociology, being qualitative was so frowned upon that I was advised I wouldn't be able to get a job if I didn't add a survey to the ethnography I was doing for my dissertation. But today, 24 years later, that looks a lot different. Topics like medical gaslighting, which I'm going to bring up more, are part of the mainstream. We have interdisciplinary departments like my home of health and behavioral sciences, and fora like this MixTape session, and a wide range of methods are acceptable and they can be worked in all combinations. And I think that is fantastic. But I think dissemination, this relationship between the content of our research and where we place it, where dissemination is today is about where these other topics were 25 years ago. And I'd like to use my time to spitball on this a little bit in the context of my recent journey with my research over the last couple of years. So mostly over the years, I have played ball with cranking out articles. I've looked at topics like how doctors try to figure out how compliant we are with our treatment regimens, how women get missed for heart attacks, and things like how mental illness stigma matters for our physical health care. In each case, the punchline is that structural characteristics of healthcare, and not just individuals, contribute to unequal outcomes, even though we like to dress all that up sometimes as patient preferences. Then in 2001, my mom died and I was her caregiver. And after that experience, I started turning my analytic gaze to the case of end-of-life care. I started asking things like, why don't more people get the kinds of end-of-life care they want? What happens when we rely on unpaid labor of women and women of color to do the work of caregiving? How do structural issues play into this? So I took this up as a formal research agenda for like the last decade. Fast forward to 2022, and I'm kind of doing my end of life thing. I'm blissfully unaware that the term medical gaslighting has taken on a life in social media circles. What is medical gaslighting? I had to ask. Well, many people, women and women of color in particular, are describing in social media this frustrating experience where they go to the doctor to complain about a physical symptom and are basically dismissed. And they're told that it's either psychological or idiopathic or because they are overweight or stressed out. And I have had women tell me that doctors told them things like, take a bubble bath or get your nails done. So a New York Times columnist writes an article on this topic and pretty prominently showcases my work. And this triggers a cascade of media engagement that is still going on. And I found out that this medical gaslighting issue spills into a wide range of topics, like this one from The Cut on period pain going unmanaged for 18 years, or this NBC one about medical mistakes being more common in women and minorities. And a lot of these media things I've done are call-in radio shows or articles where people can post comments. And people share the most devastating stories about their experiences being mistreated by healthcare. And I find myself sitting there in my head, like, yeah, I'm not surprised. And increasingly asking myself, like, what can I do to be more helpful? Now, at the same time, in this parallel track of working on the end of life stuff, I've been thinking seriously about writing my first book on this topic and making it a trade book so it can reach people who need it. Now I'm at the point where I've developed the project enough to land an agent. And as part of my platform, she encourages me to start up an Instagram account to disseminate my research and practice talking and exchanging with these real life audiences. So this last spring, I started this project and I post things like, point of view, I've made 53 phone calls, sent 103 emails, spent 6 days on hold, and I still haven't gotten answers to my healthcare questions. Point of view, aced it with asking for a goals of care conversation and palliative care consult. And also more serious posts about, explainer posts, sometimes videos, sometimes sort of micro blogs about articles that are being published that I think can use a little translation to get from academia to real people who might benefit. And then trying to bite off bites and creating these educational, these are like carousels with, again, like micro blogs or just providing more information and explainers and small views. So I start building more networks that lead to other outlets, like this one I pitched last spring for Maria Shriver's newsletter. And I'm going to say more about this in a second, but just in a few months, I start to see how these efforts are pushing me to better understand my conclusions, the implications of my work, and the ways I write about it. The dissemination and research are shaping each other in a reciprocal fashion. So here's more about this example. The guts of this post with the Maria Shriver newsletter are 3 lessons for how to get more of the end-of-life care that you want. And it boils down to these recommendations I made. Doctors don't always know more than you do. Be proactive and ask questions about the end-of-life care, about care even before you need it, and educate yourself about the kinds of care available to you. Now, a year ago, I had drafts about this that talked about things like divergent ontologies or biologizing a social phenomenon. And it has taken a lot more effort than I would have thought to not only strip out the academic language, but really work my way through the whys of what was happening to the problem of what people should do about it. And I don't know if I could have gotten there without this ongoing conversation coming from lay people to me instead of just the reverse. And that is letting me reach goals I aspired to since the start of my career, but I certainly would not have attempted sooner. So the question I put on the table, I ask, can we sustain the idea that research is essentially what it is, unchanged by the audiences who engage it? And I think we could, but I think that's not the future. And not that everyone needs to be doing this kind of work. After all, this is one season for me in a long career. There are many ways to build a career, but it matters because structural definitions of what is good research very much affect the content of the work we can do, where we get jobs, and where we need to publish to be tenured or promoted. So the question I want to raise, and the one that I hope is obsolete in 25 years, like the ones I raised at the start when I was a new PhD at Minnesota, is to ask where and how we can be more inclusive of diverse dissemination strategies and recognize how outlets are necessarily connected to the knowledge we produce. So thank you so much for your time. I would be remiss if I didn't invite you to come check out some examples of what I'm talking about on Instagram. I hope you have a great session. Thank you so much, everyone.
All right. So what I hope that we've seen today are the ways in which the work that we do in the College of Liberal Arts and Sciences is a figurative heart, right? Giving voice to stories, which was another through line that we heard today. Taking seriously the needs of real people in the context of their everyday lives. sharing with communities who need it and partnering with communities who need it about the importance of this research. We've had 4 really amazing presenters and a 5th poet today, and I hope you'll join me in giving one more round of applause to them. Ellie Lewis has arranged for a photo of those presenters, the Dean's team, and hopefully we're so glad you're here, Provost Nakuma and Tehran Kayaolu. So if in 2 or 3 minutes when we close, and I'm not quite there yet, I'll ask those people to migrate under the CU logo so that we can do a group photo in just a moment. I did want to invite those in the room to take a serious look at some of the offerings related to healthcare. Sometimes it's just a couple of certificates. You might even have classes already that count towards a certificate, and you take 2 or 3 other classes and you have an extra certification to add to your resume. I also want to ask those who are able to stay, especially my MixTape steering committee, that I want to say thank you for all of your efforts to help rearrange the tables by clearing them of the food and paperwork and so on. Students, please take a CLAS coffee mug, and faculty, staff, community visitors as well. I hope that you'll mark your calendars for our next MixTape, which we're trying a Friday this time instead of a Thursday. And the topic is technological transformations. The tones of change, I think, is the subtitle. Yeah, that is the subtitle. And we're going to have 4 different takes on technology, from AI to historical approaches. And for those of you who do research on health, and I see many of you in the room, look for future emails from the CLAS Dean's office that are asking for input regarding future collaborations and large-scale projects where we can really harness the different approaches, voices, methods, and disciplines in the room. Students, thanks so much for being here, and I hope everybody has a fantastic day. Thank you.